Welcome back to the Faculty Factory podcast, friends. It's Kim Skorupski here at the University of Texas Medical Branch in Galveston, Texas. Did you know Galveston is the first city in Texas to have telephone, electricity, elevators, and air conditioning? I bet you didn't. I didn't either. Friends, I'm looking at a frequent flyer here now, Dr. Adam Wolfe. Hi, Adam. Welcome back to the podcast.
Hi, Kim. It's great to be here. Thanks for having me back.
All right, folks, who is Dr. Adam Wolfe, MD, PhD? Dr. Wolfe is an associate professor of pediatrics, the program director for the pediatric residency program, assistant dean of medical education, the Jan L. Harrison Endowed Chair in Pediatric Graduate Medical Education at Baylor College of Medicine in San Antonio, Christus Children's. Dr. Adam Wolfe was here last time, not too long ago, talking about an article that I read, and I kind of reached out to him in MedEd Portal. It was entitled Put Yourself Out There, a strategy for effective self-promotion in academic medicine. On point, great article. It's episode number 320, 320. Dial back and take a listen to that episode. And today, Adam and I have been spending way too long just catching up with so many. It's an interesting conversation. You're going to love this episode. He's going to start us off talking about conflict resolution. So thanks again, Adam, for being here. I can't wait to get into it. Let's go.
As we've discussed before, my reason for getting into medical education as a career really stems from wanting to teach more about communication skills. So this is you've chosen an area that's really near and dear to my heart, and one of my favorite things to teach. And my understanding about conflict did not come from med school. It did not come from residency curriculum. There's very little in the medical literature about how to teach learners or ourselves about how to manage conflict in the workplace. And yet, I think we could all easily imagine examples of conflict that we've seen in clinical settings, in teaching hierarchies, throughout our leadership roles, managing conflict as leaders too. And one of the things I came here wanting to do so I joined a new faculty in San Antonio at Christus Children's through Baylor College of Medicine in 2014. It was a brand new faculty. They were starting a brand new residency program. I was able to get an appointment as a founding associate program director of this residency program. And one of the things I came here wanting to do was develop an advanced communication skills curriculum. And conflict resolution was one of the first things that we introduced. And the way that I was taught to address conflict actually was not in a medical setting. It was while I was in grad school. I actually was a volunteer leader for a national nonprofit that does a totally different kind of education than medical. It was a different world for me. And all of their leaders get trained on conflict resolution and team formation, actually using the same tool. You can use this same tool to develop a team or to manage conflict when it arises. I've found it to be most effective to do both. And so I guess before I dive into that, though, I'm going to ask you a question. I usually ask this of audiences as a rhetorical question, but since it's just us, I'll ask you directly. So can you imagine a time that you were in a conflict with somebody and you drew the conclusion pretty quickly that I just can't work with this person? We are incompatible. Interpersonally incompatible. Has that ever happened to you?
That's initial. Yeah, I can recall one person, yes, where I thought, ooh, this one's going to be a prickly pear. And I thought, this is a challenge because I always think of Abraham Lincoln. Ooh, I do not like that man. I must get to know him better.
There
So
you have a much better approach to this. When I ask learners in this, they usually can come, if I ask them non-rhetorically, they can usually come up with a lot of examples where it's like, I just can't work with that person. And I think the most effective tool for conflict resolution I learned, it was actually originally published in the Harvard Business Literature. I want to say back in, I think it was 1972 was the earliest reference I was able to find. As usual, I feel like we have to go to business in order to learn some tools about communication skills and self-management and professional development. I think they're usually way ahead of us in medicine. And so the tool that I learned and that I've been using for 27 years is called Grippy. It was published by Noel Tishy, I believe, originally back in the 70s. And Grippy is an acronym. It's GRPI. And it's in that order. So somebody asked me one time if I should like rearrange it so it could just spell grip, but then you're missing the point. It is a hierarchy starting with G and ending with I. And so the G is goals, the R is roles or responsibilities, the P is processes or procedures, and the I is interpersonal interactions. If when you start to notice a conflict, and the earlier you catch this, the better it goes. If when you start to notice a conflict, you start at the G and work your way down, the principle is that you will find the source of the conflict before you get to I. In other words, the probability that the problem is really just we don't get along is really low. And the probability that it's a goals mismatch is actually really high, which is why you start there. I was reminded of this actually a couple of weeks ago. I've been listening to your back catalog, and about a year ago, you had a podcast with Ludi Shi where you talked about meeting management, and both of you had what sounded like a very visceral reaction about people who call a meeting without an agenda. That's basically a goals mismatch. So you're going to walk in already upset. You're already primed for conflict because you don't know what you're trying to accomplish. And the person sitting next to you doesn't know what you're trying to accomplish. And so if you both expect different things, you're already going and the person in front of you leading the meeting is expecting something else, you're already going to be in conflict or less likely to work together well. So the G is goals. And I think the fun example of this that I give when I'm teaching about this is my second son, who when he's now 15, but when he was 7, he was in second grade, kind of a smart aleck like me. And he would come home from school and I'd say, how was school today? Fine. What'd you do today? Nothing. And every day I got nothing, 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 nothing. And finally, one day I said, what'd you do today? Nothing. I said, how did you know when you were finished? And he couldn't come up with an answer. When you don't know what you're doing, you don't know when you're done. So that's to me, it's a meeting without an agenda. It's a conversation or a process without goals. And so I got the attention of my program director in residency when I was an intern, actually, by unconsciously using this strategy. Our program had one representative from each resident class on what would now be called the Program Evaluation Committee. It was then called the Resident Advisory Committee. And I was the intern representative at my very first meeting. And here I am surrounded by all these faculty who represent multiple core rotations in the program. And I didn't actually understand what the purpose of the committee was yet. And I'm sitting there, and on one side of me, I'm hearing the nephrology rotation director, and on the other side of me, I'm hearing the genetics rotation director, and they're arguing about the curriculum and the syllabus for the endocrinology rotation. And that person, I'm just randomly picking the specialties. I don't quite remember what that one was, but that person wasn't even there. The person whose rotation they were critiquing wasn't even there. And they were actually kind of feuding about what they wanted to see in this other rotation. I interrupted them, and I was like, I'm sorry to interrupt. I know I'm brand new here. Could somebody just quickly refresh me on what it is we're trying to accomplish? And the conversation ended. Oh. The argument stopped and they were like, oh, wait, well, we've kind of gotten off track. And once we went back to goals, the argument ended because we realized that we'd strayed from what the purpose was supposed to be. So if you start with goals, you can often end a lot of conflict by simply restating what it is you're all trying to accomplish. The same principle works, and I know we'll get to this later, the same principle works when you're talking to families in a clinical situation, where if you have to bring them news that's unwelcome or surprising, starting with what everyone's goals are for that patient, and being able to say, we all share the same desire here, the same outcome, or we understand what the outcome will be. If we get to that point, then the rest of the conversation is a lot easier. So G is goals. It's my favorite thing because usually that ends it. And actually, my then program director brings up this thing that I taught him Grippy from that after that. Pretty much every time I see him, we bump into each other at national meetings and we talk about it. But he came up to me after that meeting and he said, "Adam, how did you do that?" And I said, "Do what? How did you end that argument?" And I didn't realize I was ending the argument. I just asked what our goals are, right? So it's not too hard. The R in Grippy is roles or responsibilities. And what you're trying to do is you're trying to make sure that everyone in a group or on a team or part of whatever the project is are aware of what each other are supposed to be doing. So not only do I know what my role is, but I know what your role is, and I know what this person's role is going to be. And I understand it. I understand where mine ends and someone else's starts so that we're not competing or overlapping in what we're doing. And this is the hard part sometimes. I agree that all the people with those different roles have the skill sets to do it. So somebody was not assigned a role that they're not qualified for, that they really don't have time for, or something, or that I could do better, or something like that. So that all gets unpacked under roles. This can be really helpful. And, again, I'm a residency program director, so I always think in terms of clinical hierarchy for conflict. But this can be really helpful in the setting of disagreement between residents on a ward team or fellows and residents on a ward team. If you think about it, so we've got residents who were interns last year and are now second year residents, and we start putting them in charge of interns the following year. So now a PGY2 is a leader of interns and medical students on a ward team. Those residents, the second year resident might think, oh my gosh, I struggled so hard with efficiency early on in internship. I am going to do these things for my interns. I'm going to take certain things off their to-do list to help them get acclimated and not feel overwhelmed. The intern, if they don't talk about this, the intern could see that behavior and think, oh my God, they don't trust me. They're doing my work for me because that senior just doesn't trust me. And I haven't even been here that long, and already they don't trust me. And you can see how that would immediately lead to an interpersonal assumption, where what it really was the goal of the second year was different from what the intern might have expected. And then the second year took over a role that the intern was expecting to have because they never had this conversation. So that's where the R comes in grippy. If you agree on your goals and you're still not quite getting along, then you move on to roles and you make sure everyone has a clear understanding of what they're going to do and what their skill sets are. And then if that doesn't work, then you go to processes and you say, okay, or procedures, and you say, okay, I'm at P. We never discussed how we're going to communicate. So, for example, I'm working with a group of co-authors on a multi-author paper, and we never planned in advance how often we're going to meet to check in. And I haven't heard from anybody for 2 months, so they must all be blowing off the job. Right? Again, I'll leap to interpersonal because that's where our minds like to go. There's nothing wrong with interjecting our emotional response to things, but being mindful about it and realizing that may not be correct is important. So then to be able to say, okay, I need to reach out to this author group. Let's establish how often we're going to check in with each other, what will be the process for backing out if I need to get out or diminish my role. Like, those are the ways to keep it professional and not let interpersonal creep in. And I can only think of 2 times in 27 years that I've used Grippy to try to resolve conflict and couldn't do it with GR and P. So that's non-scientific, but my anecdotal experience is that usually if you use GR and P, then you don't get to I, which is interpersonal. And that's where the conflict might really be this person. For example, this person is lying to me. Like, they told me to my face they agree with all these things, and then they just don't do it over and over and over. At some point, you might get to that conclusion, but I think it's really, really rare. So that is my, the way that I teach conflict resolution to residents. I have a pocket card that I keep a stack of them on my desk, and I give them out, and I say,
"You just held it up. I love it. It's a laminated card."
Yes. I mean, no, they're literally sitting right there. I didn't prep this for today's podcast. But I think it's really important to be able to have a simple way of, when you start to get really hopped up and upset in a conflict situation, to have a quick, just as quick of a reflex neuron arc in your brain that says, wait, let's go to goals. Like, let me just, before I get really mad, let me just get to goals and start to think about why we might be in conflict. And it probably isn't that they're trying to upset me, or that they're trying to be untruthful, or they're trying to be unproductive. That other person might have some other expectation that I have not explored or not understood. And that can help a ton. And so again, by putting I at the bottom, the goal of this entire strategy is to preserve interpersonal relationships. You don't have to be friends with everybody, but you should be able to get along. We shouldn't necessarily be in conflict with the people we work with on a regular basis at an interpersonal level. And that is a starting principle for this. It's not unlike the principle in the business world for operating agreements. The first principle of operating agreements is assume good intent. This is kind of along those same lines where I assume that we are interpersonally able to get along. And I'm going to do everything I can to preserve that, even when we disagree, which is inevitable, right? Anytime you form a new team, conflict is inevitable. So it's not like we can prevent conflict. It's not like we even want to prevent conflict. Sometimes you learn from conflict or you make your team better, but you need to do it in a way that people are still able to get along after you're done,
Yeah.
in my opinion.
There's so much richness in what you said, Dr. Adam Wolfe. I love all of this. And what you just said triggered something in me. We want to preserve relationships. And I think what I'm feeling right now is this idea that we don't have to also be best friends with everybody. So, the idea of preserving relationships begs the question of what kind of relationships are we talking about here? You don't have to hang out after work and hang out on the weekends and have your kids be best friends with their kids and everything's hunky dory and it's just this like a sitcom TV show that we're all just kumbayaing all the time. I like that you said, gosh, we don't want to have groupthink all the time, that we're all so enmeshed and in sync, perfectly aligned all the time, because then where's the novelty? Where's the innovation? Where's the push to kind of step into discomfort by maybe doing something differently or thinking differently or challenging assumptions and challenging ways of thinking and trying new things. So we don't have to think that, well, this is failing because we're not all best friends, that we're not all hanging out together. We just have to, as you said, preserve the relationship. And so there are different levels of relationships. And so that's what I'm kind of getting from that. The way that grippy is, that the interpersonal is at the bottom. It's not like, let's start by team building and let's make sure we're all best friends and fall off of tables backwards. And then only then, when we're all besties, can we work together as a team. Not necessarily. So this kind of flips it on its head. And as you're saying, an assumption would be, we all want what's best for the patient here, or we all want what's best for the student or the learner, don't we? So you're starting there with, if we all have our eye on the same prize, we can get there, as you pointed out, in different ways. You can own your own process, you own your own procedure, and we're all going to get there in our own ways.
Well, you jogged my memory on something that's really important, which is, so yes, when you're in conflict, I don't start with the kumbaya and the team building part, because my leadership style is generally, if you're familiar with the DISC, is very D, which is like seeking out problems to solve. And one of my weaknesses on that spectrum is not stopping to celebrate victories. The flip side, however, if you're too much of an I on that metric, is you celebrate victories perhaps at the expense of acknowledging conflict or problems. And so I have one thing I have to guard against, and then there are other people who might have to do the other. So what I wouldn't want to do is, when people are in conflict, appear to gloss over it by saying, let's focus on how, what great friends we should be. But since you brought up team building, I think the other thing that's important to remember is that when you're starting a new team, so every year, for example, when my GME team turns over the chief residents, 2 of them graduate, 2 new ones come in. That's a change in our team, and I consider that a new team forming, even though 4 of us stay the same, or 5 of us. And the other principle that comes out of the business world, not medicine, which I do teach alongside conflict resolution, is the 4-phase model of team formation, which I don't know if you're familiar with this, but that when you bring new people together, or you take an established team and swap in a new member, you enter a phase that's called forming, which is people have high motivation, usually high enthusiasm. That's where your team building is helpful. They can get to know each other and you can form some of those initial relationships, but their efficacy is low because they don't know each other very well and they haven't learned their jobs. I think of a brand new intern class. They come in really enthusiastic, really excited to get to know each other. They can't really do anything yet. We don't expect that of them, but that's the forming phase. And the issue with conflict is It's most likely to happen in the second phase, which is called storming, which is after people get to know each other well enough past a certain point. Now they know each other well enough they can start to disagree. And that's where their initial early, maybe improving performance could drop again if they stay in conflict. And so when I teach about conflict resolution, I do talk about how forming is a really important time to develop those personal or professional relationships that are cordial, if not friendly. They can be friendly, but cordial at least. But then they are threatened if you get to the storming phase and you don't have a strategy for how you're going to overcome those conflicts. And then, of course, if the team stays the same, which rarely happens, people change or personnel change. But if the team stays the same, then they can enter the latter two phases, which is going to be norming and performing, which is where they're working together so well because they've established those roles for each other. They've established processes, and their efficacy is very strong. But since you had brought up team building, I was thinking like, yeah, you got to remember that forming phase. That's where getting to know you and kumbaya stuff. I mean, we say that kind of pejoratively, but I think it's very important to give people a chance to get to know each other personally and have some friendly relationship before you risk getting into conflict.
And so, Adam, you also said something, you mentioned the DISC personality assessment, and there are many, assessments out there, the Clifton Strengths and the Myers-Briggs and the DISC and the EQI, et cetera, et cetera, et cetera. And what I really appreciate with all those tools is the idea of self-reflection, knowing yourself to better manage yourself, and then giving you some skills to gain insight into others, and then trying to manage those relationships. And so that's what I appreciate about that, taking a moment to appreciate, using that pause, that moment of, okay, I'm about to enter into a fill in the blank meeting, classroom, patient room, presentation. What am I walking into? Who is my audience? That moment to pause and think about your perspective and your posture as it relates to others and what people expect of you can help set the tone for that encounter, whatever it is. And so I like how earlier on you gave an example of, going into a meeting with an expectation or assumptions of, I'm super busy. I never got the agenda. It wasn't in my Outlook invite. I have no idea why we're meeting here again. I know that so-and-so is out of town. So if so-and-so is out of town, why are we even having this meeting? So I'm getting myself all amped up. And to take that moment of, okay, hang on a second, a little bit of grace and mercy. Who's in this meeting? What's our intention? And then maybe the whole, hey, it's nice to be together, everybody. I'm just kind of curious, so-and-so is out of town. And it made me wonder, do we have an agenda? Is there some, what are we going to cover today? By the end of our meeting today, what do we hope to accomplish? Asked with that kind of open and true intention of authentic versus being all passive aggressive about it. But so you're making me think, when you talked about the grippy model, Adam, I couldn't help. I kind of got stuck on the goals thing. And I see why it's so important to really clarify that and gain clarity around what are our goals. Can you give us an example of sometimes when I'm thinking you can't kind of agree on the goals, or is it a process? I'm thinking of a recent issue where, gosh, we're having an event, we're organizing an event, and a couple factions, if you will, are in conflict because on one hand, maybe you have the one group of people who their goal was, the purpose of this event is to impart knowledge, to share information, to teach, to give some guidance around how to do a thing. And another group is, we are wanting to bring people together. We want people to network. We want people to get to know each other. We want to build relationships. We are trying to build community and build bridges. So there's kind of, maybe if in Myers-Briggs parlance, you have a high thinking group or a high feeling group. And no matter how hard you push, the one group is like, we just have to, have a PowerPoint presentation and handouts and maybe give them a bottle of water. They don't need anything else. And then you have another group of people saying, what's the point? Why are people going to come to that? They would just go on Zoom, just give them an email. I mean, so how do you help people clarify that goal, or am I too stuck in the who, the roles and responsibilities, or the how we're doing it? Help me figure that out.
That's goals. What you just described to me sounds like goals. And so that's the other thing that I teach residents before I get to answering your question, because you reminded me, is many conflicts appear to be multiple things. This could be a goals problem and a process problem. Whichever is higher is where you should start, because you can't solve the process problem if the goals are still mismatched. So in your case, yeah, there may be some roles and process stuff, but goals seem to be not necessarily incompatible, but perhaps not agreed upon yet. And so your example is wonderful because I noticed, I'll disclose, I have no stake in your upcoming mid-level career faculty development series in April. But I remember hearing your commercials for it, and this will probably air after that happens anyway. But in there, you talk about all these great presentations you're going to have where the participants are going to learn skills from national experts, and you added on half-hour sessions each day or multiple half-hour sessions each day for networking as part of that session. So what came to my mind when you were giving your example was, well, gosh, as long as people express what their goals are to the larger group, then whoever's facilitating might be able to look at the situation and say, why can't we have both? Why can't we share all of those goals together and say, we are going to have some, and this is how most national meetings tend to work, right? There's networking sessions and exhibitions and like galley type exercises or cocktail receptions or things where people can socialize, and there's scientific content. You can manage to fit both of those types of things into one session. The mistake would be letting some people in the room have an expectation that they haven't voiced or it hasn't been discussed, and then other people in the room have a completely different expectation that hasn't been discussed, and then they will never get along when it comes to planning your event, because some people are going to be pushing for things that facilitate networking, and some people are going to be pushing for scientific content. You could argue that both of those are extremely important for professional development of anybody, but particularly in academic medicine. I just came back from a national meeting, my favorite one, because most of the people in my network go to it. And I would want both. Like as a participant, my goal is to have both of those things. So if you couldn't do both things in your example, then I would almost suggest that whoever's leading reach out and poll the stakeholders who are going to be part of that, whatever you're planning, and find out what they want. Like develop your goals around what will actually accomplish the needs of your stakeholders. That's another way to do it. There's no one right way to do this. The Grippy model doesn't solve the conflict. What it does is it gives you a scaffold on which to figure out where the problem is. You then have to do the hard work of aligning those goals or accommodating all of them.
I want to circle back to something you said earlier. I think it was before I hit record button. It was about, let's take the Grippy model into a patient encounter where, as you put it so eloquently, not necessarily breaking bad news, but providing life-altering, if not life-threatening information. And you gave a good example of, for instance, if you're with your healthcare team in a room with mom and dad, with parents, and the child, and you're all discussing a treatment plan of what happened to this kid, and maybe you as the healthcare provider team have a goal of getting this patient back to optimum performance, or treating them of whatever happened in this accident, and the assumption that we as healthcare providers could make that, well, surely you want this bone, as you gave an example, to heal completely, and so that he'll have a good quality of life in future years. And you're thinking, right, parents, does that make sense to you? And parents are thinking, yeah, we also want this child of ours to live a long, healthy life. And so we will do whatever it needs to do to give this kid long-term impact. And then the third party in there is that child, the person, like, what is he, in this instance, in the example you gave, what is his goal? So what I think is so powerful about this is the awareness, the recognition, as you're saying, as of the goal and how it can be all of those things. So I like how you pointed out it's not an either or necessarily. Minimally, it's a recognition of, hey, folks, I'm in this meeting, we're talking about this event. In my mind, my goal is, just like when you set up an objective or learning objective, is to impart this information for change in knowledge, attitude, skills, behaviors, what have you. So I'm thinking this way. And I want to provide space for someone else to tell me, what am I missing here? Oh, Kim, this would be great, for folks to get together and to get to know each other. There's a lot of, siloing here. And oh, that's reasonable. That makes sense. So that's kind of that openness to, as we were talking about improv, yes, and. So can you take us back to that patient room and using that grippy model and giving us another example of that resolving and focusing on the scaffolding you talked about?
Yeah, I think it's a great question, and I will add the not really a caveat, but the twist on this is that when you are entering clinical communication, so if I'm treating a child and their family, then it's a little bit different from if I'm working with peers to run a meeting or to plan something, because this is me editorializing, but my opinion is that as a clinician, I should not be walking in the room and dictating the goals to the family or assuming what their goals are, because they're going to have probably a completely different view of things, a different understanding, different social and cultural background, different things that govern their decision making and what's important to them. So when it comes to trying to apply this model to a clinical situation, I use it with a different mindset. I use it as a team formation or a process formation tool rather than conflict resolution. Because by the time I get into conflict with a family, I've kind of missed an opportunity to create an alliance with them, or it's going to take a lot of energy to earn it back. So I don't, and they will assume it's interpersonal, that I don't care, that I'm rushed, that I'm not interested, or I don't know enough, or whatever it is. I don't want that to happen. So Grippy can also be useful as a team formation tool. And if I'm writing a white paper to propose a new curriculum or a new position or something, I write it in the order of G, R, P, and I. Not usually I, unless I need something personally from those people, but I'll write the goals, roles, and processes out. I can think that way as I go into a room. So going back to your example, okay, so we have a teenage athlete, 17-year-old boy breaks his femur in a football game at high school. It's September, it's early in the season. And we're seeing them in clinic, and now I'm an oncologist, so if I'm seeing that patient, that's really bad news. But let's say that you're the orthopedic surgeon, you're seeing this patient in your clinic. He's broken a bone. It's going to take time and immobility to heal. It's expected to heal fully. This is a healthy patient. I could walk in the room and be like, this is routine. This kid's going to be fine. He won't have permanent disability. We'll get him back on his feet in a few months. And I have to tell him that he's going to have to sit out the football season, which to me is not a big deal because I have a longer view and I can say, well, gosh, there's going to be more football seasons. This kid's 17. He's a senior in high school. This may be very, very important to him, even if he doesn't have the long view that I'm trying to take. So I have to be appreciative and inquisitive to learn how important the football playing is going to be to him, to really appreciate how badly he will take the news that he has to sit out the season. Even if it's not life-threatening, as you said, it is life-altering for this child. Now let's layer on the fact that this is Texas. Football is basically a religion. This kid may be getting scouted for college ball. And if he has to sit out this senior season, he may not actually get into college or have a scholarship to be able to go where he wants to go. This becomes more life-altering than simply sitting out a football season and healing your broken bone. I don't know any of that walking into the room unless I happen to already know the patient. So my goal is to help him heal because I don't want him to have permanent disability. But if I just march into the room and impose that on the family without first asking some questions about what they understand, what their values are, how important this is going to be to the child, I realize that takes some of the, frankly, too short 15 minutes that insurance allows us to spend with our patients. But if I don't know those things, they're going to walk out of there so upset with me. So much more upset with me, whereas I would like for them to be allied with me to help the kid get better as quickly as we can, as thoroughly as we can, without them saying, we're not going back to that guy ever again, right? So, and I'm not picking on orthopedic surgeons because the ones we have here are outstanding and I've sent my own kids to them, but you want to make sure that even though I know what needs to be done, I can't tell this kid he can go play football. He's got a broken leg. But I can't just march into the room and be like, here's the prescription, you're going to be fine, adios, see you in
Yeah.
6 weeks, without threatening the relationship. Right. So that would be my sort of shorthand way of thinking about the goals part is really important. And frankly, when I teach about what is in the literature as breaking bad news, but as you noted, I call it sharing life altering information so that I'm not judging as much. When I teach about this, I actually teach using a different mnemonic, which is well published in the literature called Spikes. It was published in 1990 by Bale as originally for medical oncology in adults, but it's been used extensively in pediatric, particularly not pediatric, all residency education for breaking bad news over the last 30 years, so 35 years now. So I teach a modified version of Spikes that we developed back in like 2013 to make it a little bit more pediatrics friendly. But the P in Spikes is perception. What is the family's understanding of the diagnosis? What does this actually mean to the child or their family members? It's the same thing as starting with goals in Grippy. It's showing that you're paying attention to what's important to them and demonstrating that you value that too, even if we can't honor everything they want.
What does Spike stand for?
So it's a mnemonic, again, originally published in 1990, but it's been used a lot now in the medical education literature. There are others for this phenomenon, or for teaching this, but I think Spikes is the most universal. The first S is setting. And that is, am I in the right place at the right time with the right people present? And this is not usually an issue in a clinic because people show up at a certain time in a certain place. But the bigger issue is on an inpatient service, are the right family members present if I have to come tell them that MRI showed some new tumor? And for pediatrics, which is my specialty, should the patient even be there? If the patient is 5 years old, is she in a place where she can participate in a conversation about her cancer diagnosis or whatever the thing is? And will the family find it a distraction if their happy 5-year-old is in the room while I'm telling them news that they may find quite upsetting? And these are the sorts of things that you have to assess in advance. And it can be as simple as, I got those scan results we were waiting for. Do you want to talk as a group, or would it be okay if I have a child life specialist, watch Zoe here for a few minutes while we go talk? Like, everybody's different. So we did some research on this, like I said, about 12 years ago at the University of Wisconsin, where I was a fellow. And we found that families were not all on the same page about this. It depends on the age of the child, the developmental status and capacity of the child, and then what the family prefer. And so we got all kinds of different feedback. So you just have to ask. And then that feeds right into perception. You have to ask about this too. What do you understand of this diagnosis? In my world, have you had other family members who've had chemotherapy? Because then you're going to have a very frank sense of what that might look like. And I have to work with that as I talk about what I'm expecting for this patient. And then the I, this is where we differed a little bit. The I in Spikes stands for invitation. And that's the original publication, and that is really making sure that whoever you're talking to is ready for you. So knock on the door and say, "Is this a good time to talk?" That is an important principle, although I teach that as part of setting. We actually, for pediatrics, we proposed changing the I into involvement, making it more about respecting the cultural needs of a family, recognizing their religious influences, recognizing any ethnic differences, recognizing what language they prefer to speak in, and really trying to make sure that the communication is centered on the patient and the family and not based on my own convenience or my own, white guy perception of the world, right? So that's the way I use I is for involvement, but the original I is invitation. The K is knowledge. That's medical information. You won't be shocked probably to know that I think clinicians are great at this. We usually don't have problems sharing medical information. We like things we can measure. We like things we can describe, things that have pathways and algorithms and percentages. We're good at that. So usually the K part is not so hard, although you have to transition from the knowledge into the E, which is emotions and empathy. And that's the part we probably do the worst. When, again, anecdotally speaking, when I poll audiences, that's what people seem to think is the hardest. And actually, that's what Bale said in his article back in 1990, when he had surveyed medical oncologists. That was the hard part. But being able to make that transition to, we've gotten to know each other, and now I have to tell them something that's going to be a surprise or maybe unwelcome or really bad news, then I need to change the tone So that's where we usually teach people about something called a warning shot, which is not dropping the news, not saying, okay, it's cancer. You don't do that. But being able to say, all right, so we did get those scan results back, and it wasn't the result we were hoping for. And then you pause. This is where nonverbal communication comes in. You need to pause and let the person realize you're about to change the tone. It's an emotional palate cleanser. So the warning shot is not the news. It's not the information, but it allows them to put their brain in a mindset where we're not checking in anymore. I got something to say that they probably are not going to like. Then being able to recognize what emotions they bring to the conversation when you share it. Okay, so we did see a new tumor on this scan. This is what the radiologist thinks. This is what we might need to do about it or what it might mean. And then again, I have to pause and recognize that family members and patients could have any emotional response to a life-altering diagnosis. This could be asthma. This could be the broken bone we talked about. This could be cancer. All of those things, they will respond in their own way. People can get angry. They can feel guilty. They can get defensive. They can deny what you're saying. They can withdraw completely. My teenagers usually just bury themselves in their phone, and I actually have to respond to that as an emotional response. I know you're hearing what I'm saying. I can tell that you don't want to engage with me about this because it's probably not welcome information. Um, and then just being able to reflect back and say, I see the way you are responding to this. Again, I think clinicians are not well trained to do this in my own experience. And just giving people permission to say, you're not going to make them feel better necessarily. You might not be able to do that, but to be able to show a little bit of empathy, to be able to say, I can tell from your body language or from what you're doing, how you're feeling, or this is what it looks like to me, just to be able to show that you're trying to feel with them. And Brene Brown has done a lot of great work on empathy. She has there's some good videos that I use when I teach about this because she says it a lot better than I do. I developed this talk many years ago when I talk about this, and I show one photograph for each of the sections of spikes just as an illustration, and then I talk. I don't put the words on the screen. And each of those photos came from a trip I took to Cape Cod many years ago, and I just had a bunch of really interesting pictures. One of the pictures that I used to use when I talked about involvement was a photograph of what looks like a family of cormorants on a rock sitting in the middle of the water right off the coast of Cape Cod. And I say, look, we're healers. Our natural inclination is to reach out to those folks who are stranded on that forbidden space and gather them up and bring them back to the shoreline with us. And as healers, we do want to do that. People who mean well want to do that. But as I thought more about empathy, I actually changed the way I teach this. And I now use that photograph to describe empathy. And I tell people, I actually use it for both, but I go back to the picture and I say, okay, remember I told you we want to reach out and gather them up and bring them back to shore to feel safe and secure again. That may not be what they want from us in the moment when we tell a family something that has rocked their world. What they might want us to do instead is try to get out there on that rock with them for a few minutes and just be there. And sometimes you can't say or do anything that's going to make them feel better in that moment, but you can try to show that you're there with them and just listen or just be there. Or at our facility, sometimes people want us to pray with them or they want us to cry with them. And it depends on what your own personal sort of comfort level is with this sort of thing. But for me, that was a huge shift to be able to say, you know what, before I have to gather them up and bring them over to the mainland with me, I need to try to get out there with them on that rock. And families taught me this. I didn't just come to this as some sort of epiphany. Families have taught me this. And so I think listening to what our families have to say is really important. And then to complete the answer to your very short question that I've made very long, the S at the end of spikes is about the summary and the strategy. So at the end of the conversation, if I've spent 45 minutes telling a family that their child has a life-threatening condition or any chronic illness, they may have missed the middle 90% of that. Like they may not remember a lot of what we said. So I always tell them, here are the 3 things you need to know. Here's what we're going to do next. Here's how to reach me in an emergency. Here's how we're going to follow up. If nothing else, I want them to walk away with. So I end with that summary. And then I also give them permission to forget everything else. This was a lot of information. This was probably not what you were expecting to hear today. If we have to repeat any or all of what I just said a week from now or tomorrow, We'll do it. Just let me know. Think of questions, write them down. We're going to do it again. I think the S is really valuable at the end there to remind us to summarize. And the other thing we added to the S for our pediatric modification is self-reflection. So one of the challenges is if you're working in an environment where you have to have these types of conversations on a regular basis, it's pretty easy to get some empathy fatigue. It's pretty easy to feel helpless if you're telling people things that are really not welcome and they're upset about it. And being able to stop and say, okay, I don't get a do-over if that didn't go well. I don't get to do it again, but I could learn something that'll make me better at this the next time I talk to a family. Or I am really hurting right now after that conversation, and I need 5 minutes before I can go see my next patient because they need me too, and I need to be at my best. And what do I do with those 5 minutes? Do I run up and down the stairs? Do I run around the block? Do I sit in the stairwell and cry? Do I need a cup of coffee? Like 5 minutes is a precious little gift that you can give yourself in the middle of the day sometimes. So to me, that self-reflection is really important, and it does help us stay a little bit healthier when we have to do this regularly. That's spikes.
Oh, wow, wow, wow. Dr. Adam Wolfe, I can see why you are an advanced communication skills genius. You have laid down some great wisdom on us today. We talked about grippy, team building, and spikes. And what is so cool about this is I entered into this conversation with this mindset of conflict resolution. So I'm thinking crucial conversations, difficult conversations. And what is so awesome about this is the grippy model. This is not only resolving conflict, it's preventing conflict. Using
Got
this
it.
tool as you said earlier, it's about preserving relationships and everything in leadership, gosh, in life is about relationships. We are
Relationships.
humans in constant relationship. And so if we can just pause and just always remind ourselves relationships, even if that kind of sounds icky or gross, that's what everything is. It's just making sure that we are all aligned and where are we going. And that to me is number one, is that relationships is key of everything you mentioned today, the communication, the grippy, the team building, the spikes. It's all that awareness and sensitivity to other human beings and getting out of our own head and trying to gain some insight into other people's heads and hearts. So thank you so much. It says, I'm going to leave the final parting words for you. I just have learned so much from you and thank you so much. And before we peace out and I give you the final parting words, I do want to, folks, share the email address for Dr. Adam Wolfe, because I know you'll want to get in touch with him. He can come to your institution and obviously do lots of wonderful work with you. It's Adam, Adam, period, Wolfe, Wolfe, at BCM, stands for Baylor College of Medicine, bcm.edu. So adam.wolfe with an E on the end of it at bcm.edu. And Adam, please, you give us the final summary words, and we'll leave it with that.
So thank you so much, Kim. As you might have figured out, this is some of my favorite stuff to teach. So you've triggered me in a good way. I will just say that as I did the last time we did this is work that requires a lot of people, and I could rattle off a list of 10 names of people who've helped me develop these curricula, refine them, teach them, and eventually publish them. And what I would just say is two of the things you've already said, I'm going to repeat as a summary at the end of a conversation, that developing networks and having relationships professionally is one of my favorite things to do. And I think it has helped me be better at advocating for my learners to find jobs and find partnerships. I think it has helped me develop my own career, and I think it's developed some lasting friendships as well. So I think that recognizing that, then my second take-home point is do whatever you can to preserve your interpersonal relationships. So if you are in conflict, try to think, even if you don't use grippy, if you have a different way of doing it, just try to think about how to preserve those relationships so that person remains available to you and you to them when you have opportunities for partnership or for collaboration, because that is what I think makes this work rewarding. That's what makes academic medicine different for me. So thank you.
Thanks for tuning in to the Faculty Factory podcast. We are a faculty development community sharing tools to build academic leaders in healthcare. Maybe you want to be interviewed on the podcast? Please visit facultyfactory.org/contact and send me a message there. The Faculty Factory podcast and website is sponsored by the Office of Faculty Affairs at the University of Texas Medical Branch in Galveston, Texas.